Mabuhay, I am Dr. Kate Villamin, and today I will be presenting my research entitled Dermoscopic Features of Common Hypomelanotic Diseases of a Tertiary Institution, a Descriptive Study. This will be the flow of my report. Dermoscopy, also known as dermatoscopy or skin surface microscopy, is a non-invasive diagnostic tool that allows visualization of subsurface skin structures not visible to the naked eye. It is especially valuable in evaluating hypopigmented skin conditions where subtle pigment changes can make diagnosis challenging. By examining vascular, pigmentary, and structural patterns in greater detail, dermoscopy helps dermatologists differentiate various hypopigmented macular diseases more accurately. Hypopigmented macules and patches are common dermatologic concerns due to the cosmetic impact and effect on self-esteem. They result from reduced melanin, producing lighter or white skin areas, and often prompt consultation because of their visibility and social stigma. Diagnosis can be challenging, but dermoscopy helps in identification, differentiation, and monitoring severity and treatment response. However, histopathology remains the gold standard. Common hypomelanotic conditions encountered in the dermatology practice in the Philippines include vitiligo, pityriasis alba, achromic pityriasis versicolor, idiopathic guttate hypomelanosis, and nevus pigmentosus. While histopathology is confirmatory, its invasiveness and limited accessibility highlight the need for alternative diagnostic tools. This study aims to analyze the dermoscopic features of common hypomelanotic macular diseases observed in the dermatology outpatient department in the Philippines. It also seeks to evaluate the utility of dermoscopy as an adjunctive tool for the rapid and accurate diagnosis of hypomelanotic skin conditions. Furthermore, the study aims to move beyond the traditional clinical pathologic correlation of skin diseases to a more comprehensive clinical dermoscopic pathologic correlation. Providing data on typical dermoscopic findings for common disorders can promote its use in clinical practice. Currently, no local studies validate findings from international researches. Incorporating dermoscopy into routine examinations for pigmentary disorders may enhance a quick and accurate diagnosis by offering submacroscopic details to differentiate between similar conditions. The study aims to describe and assess the dermoscopic features of hypopigmented skin conditions in patients at the Research Institute for Tropical Medicine's Dermatology Outpatient Department. It explores whether dermoscopy can serve as a sufficient diagnostic tool to confirm common hypopigmented lesions, reducing the need for invasive procedures like skin punch biopsies. The study used an observational descriptive design over 3 months and included all adult patients who volunteered. New patients with hypopigmented patches and macules were recruited for the study. Patients were eligible if they were 18 years or older, of any sex, and had untreated or newly diagnosed hypomelanotic skin lesions within the past year. Patients who declined to provide informed consent had previously received treatment for their lesions, such as topical medications, phototherapy, or systemic antifungals, and those belonging to vulnerable populations, including individuals unable to provide informed consent or elderly patients with cognitive impairment, were excluded from the study. And here's the withdrawal criteria. The study protocol was reviewed and approved by the ITM Institutional Review Board, and each patient. All patients underwent a comprehensive dermatological assessment, which included detailed history taking and physical examination. Demographic information, including age, sex, socioeconomic status, and relevant clinical findings, was collected and documented. Patients with scaly hypomelanotic lesions underwent a potassium hydroxide examination to evaluate for fungal etiology. Skin scrapings were collected from the affected areas, mounted on microscopic slides with 10% KOH, and examined by a trained personnel at the institutional clinical laboratory. A diagnosis of pityriasis versicolor was confirmed upon identifying characteristic fungal elements showing the typical spaghetti and meatball appearance. Pityriasis alba was diagnosed clinically in patients presenting with hypopigmented macules and patches on the head, neck, negative KOH result, and a history of atopy. Indeterminate leprosy was suspected in patients with hypopigmented macules and patches accompanied by altered sensation. Sensory testing, including the light touch, pinprick, and temperature assessment, was performed on both lesional and non-lesional skin to evaluate sensory impairment. Skin punch biopsies were obtained for the histopathological confirmation in suspected cases of vitiligo, idiopathic catete hypomelanosis, nevus depigmentosus, and leprosy following the standard aseptic protocol. In patients with biopsy-confirmed vitiligo, supplementary melan A staining was performed to assess melanocyte presence and distribution. Additionally, all lesions were examined under the Woods lamp to assess pigmentary changes and aid in differential diagnosis. All cases were examined with a handheld dermoscope using polarized and non-polarized light. Examinations were supervised by dermoscopy-trained PDS accredited consultants, and dermoscopic assessment focused on several parameters adapted by the study by Al Refu, including altered pigmentation within the lesion, edge definition, the presence of scales within the and around the lesions, perifollicular pigmentation, perilesional hyperpigmentation, hair color changes within the lesion, vascular morphology and arrangement, including telangiectasia, and the identification of distinctive dermoscopic patterns. The findings using dermoscopy were interpreted with the help of all investigators, and the terminology used in the dermoscopy followed the International Society of Dermoscopy's Third Consensus Conference for illustrating and summarizing the findings. Descriptive statistic was used to summarize the general, demographic, and clinical data, and categorical data were presented as frequency and percentages. COBO Toolbox, programmed by the Department of Epidemiology and Biostatistics, was used to encode the data. The study included only newly diagnosed hypopigmented macules and patches within the limited time period. Potential confounders were limited to basic demographics such as age and gender. It focused only on the most common hypomelanotic conditions seen in our outpatient department. So to answer research questions, in a sample of 48 participants, the demographic profile revealed a slightly predominant male representation comprising 54.17%, while female constituted 45.83%. The patients between 18 and 65 years of age with mean age of 28.31 years. In terms of civil status, most were married, followed by single and widowed at 14.58%. Most participants belong to the middle income group and followed by the low income group at 33.33%. Approximately 90% of participants with vitiligo showed no scales or pruritus on their lesions. All participants showed negative KOH skin scraping findings. And approximately 77.78% of participants with pityriasis alba had lesions devoid of scales. 66.67% have pruritus, and all had negative KOH. So this figure illustrates the clinical and diagnostic characteristic of pityriasis versicolor participants. 67.86% of cases demonstrated presence of scales on the lesion, and about 60.71% have an absence of pruritus, while 39.29% have pruritus. The majority of the participants, about 89.29%, had positive KOH findings, demonstrating the short and angular hyphae in clusters, giving them the characteristic spaghetti and meatball appearance. So this graph shows the dermoscopic characteristic of vitiligo patient. The research finding indicate that the majority of vitiligo patient, comprising 72.72%, reported having multiple depigmented macules and patches. All vitiligo lesions, according to the data, have well-defined borders and few scales. The majority, 81.82%, demonstrated the presence of perifollicular pigmentation, And in terms of location of the hyperpigmentation, 54.55% of participants have no specific changes, followed by lesional hyperpigmentation in 36.36%. Additionally, 54.55% of the participants had normal hair, while 45.45% had white vellus hair. Distinctive pattern included 40% with white diffuse depigmented white glow and trichrome pattern, and 30% with white pigment network. Histopathology showed a decrease in melanocyte at the basement membrane, which is reflected in dermoscopy as a diffuse white glow caused by the light-induced autofluorescence through dermal collagen. The sharp, well-defined lesion border indicates stable vitiligo, while features like perifollicular pigmentation, trichrome pattern, and white pigment network suggest progressive vitiligo. Hence, dermoscopic findings can help assess disease activity. Among patients with pityriasis alba, hypopigmented macules and patches were the most common presentation of lesions, which was noted in 66.68% of cases. Smaller percentages have hypopigmented to erythematous macules at 11.11% and hypopigmented globules at 22.22%. All patients with pityriasis alba exhibited ill-defined edges or borders of the lesions, have normal hair color, and lack perifollicular pigmentation. 55.56% of patients with pityriasis alba exhibited non-scaly lesions, while 33.33% have few scales and only 11.11% have multiple scales. The data also revealed no specific changes in 77.78% of hyperpigmentation, while a small portion comprising the presence of hyperpigmentation and non-lesional hyperpigmentation. A significant proportion of participants, specifically 57.1%, showed no distinctive pattern, whereas 28.5% demonstrated hypopigmented pigment network and globules. The ill-defined hypopigmented macules with fine scale were the most common features of the pityriasis alba. The lack of sharp margins can cause lesions to appear as hypopigmented to erythematous macules or globules. Acanthosis and reduced melanin results in white structureless areas, while hyperkeratosis causes fine scaling. Dermoscopic features of patient with pityriasis versicolor are illustrated in this slide. The majority of the patients, comprising 96.3%, presented with hypopigmented macules, patches, and globules with ill-defined borders. The lesions were present on the face, neck, upper trunk, and extremities in all cases. A significant number of participants exhibited non-pruritic lesions. The majority of participants displayed few scales, followed by non-scaly lesion, then multiple scales at 10.71%. 89.29% of lesions lacked perifollicular pigmentation. Distinctive patterns included hypopigmented areas with white dots and globules with fine scales along skin creases and hypopigmented areas with white blotches and pigment networks. Adjacent white dots and globules near hypopigmented areas are termed satellite lesions, linked to a decrease in melanocyte as seen histopathologically. Kaur et al. Suggested that hypopigmented networks seen in dermoscopy of pityriasis versicolor are defective melanosomes and inhibits melanin transfer to the keratinocytes. It also releases dicarboxylic acid, which inhibits tyrosinase and damages the melanocytes. The fine scales, particularly along the skin creases, result from hyperkeratosis in the stratum corneum and can also The sole patient with nevus depigmentosus in the study showed multiple ill-defined hypopigmented non-scaly macules, and there was absence of perifollicular pigmentation, hyperpigmentation, and vascular structure unaffected area. A distinctive pattern described as a faint reticular hypopigmented network with serrated margin was observed, and this faint reticular network signifies the presence of remaining melanin on the melanocytes. However, since there is a paucity of patients seen with nevus pigmentosus, more cases is needed to strengthen these dermoscopic findings. So here's to summarize most common dermoscopic features seen in the study. In pityriasis versicolor, we saw ill-defined hypopigmented areas with white dots and globules, often accompanied with fine scales, especially along the skin creases. The scales are actually one of the helpful clues that point towards superficial fungal infection. For pityriasis alba, the lesions are more poorly demarcated and typically non-scaly. Dermoscopy often shows a subtle hypopigmented network and globules, sometimes with mild erythematous changes, reflecting its inflammatory nature. In vitiligo, the findings are much more striking, well-defined depigmented borders with a diffuse white glow. Perifollicular pigmentation is a common feature and may suggest ongoing repigmentation. Other classic findings include a trichrome pattern and white villus hairs, which can indicate follicular involvement. Meanwhile, nevus pigmentosus presented with faint reticular halogens, helping distinguish it from vitiligo. Dermoscopy provides a subtle but valuable clues that improves diagnostic accuracy and guide treatment. So in conclusion, this study reinforces dermoscopy as a valuable adjunct in the initial diagnosis of hypopigmented macular diseases, supporting findings from previous literature. It's specifically useful in resource-limited and rural setting where skin biopsies may not be readily available. While dermoscopy alone is not definitive, combining it with a thorough history and physical examination strengthens diagnosis accuracy and improves patient care. Training in basic dermoscopy can further enhance clinical skills and guide recognition of key dermoscopic patterns in hypomelanotic conditions. So, a key distribution across hypopigmented disease categories. Further studies should include a larger, more balanced population covering all common hypomelanotic conditions. Multi-center studies across diverse regions are also recommended to strengthen data and improve external validity. Here are my references. Thank you for your kind attention.
Good afternoon. Thank you so much to the entire organizing committee for inviting me to this prestigious conference, and it's indeed an honor to be presenting my work on PRP here. So I'll be talking about PRP for scar management. My humble understanding about regenerative medicine is that no amount of external medication can ever match the infinite potential of our body's own healing substances, and PRP is one such elixir. While doing so, all it needs is adequate supply of nutrition, correction of underlying deficiencies, and a relatively stress-free environment. Now, as we're using very high-tech machines, we're using ablative lasers, we're using microneedling radio frequency machines, which are, which are supported by artificial intelligence. So here I'm talking about natural intelligence, which is regenerative therapy for enhancing the healing capacity of the body. So basically, we're working with enhanced natural intelligence of the body for for promoting the healing process of the body. So here, as we can see that whenever we have a scar, we can either ablate it with erbium YAG laser or CO2 laser on the surface, or we can use microneedling radio frequency machine to ablate the deeper layers of the scar. And then we have the platelets, where we can actually take very high concentration of the platelets, and these platelets, once they see the tiny bleeding vessels, they start getting activated, they start releasing their growth factors, which are platelet derived growth factor, transforming growth factor, IGF, VEGF, EGF, and so many others, which start working on the healing process of the scar, and they enhance the overall healing of the scar. So that is the basic principle of using PRP. And I call PRP an elixir because we are using it for n number of indications in our clinic, whether it's FUA transplant or in different types of alopecias or in vitiligo surgery. But practically here, I'll be talking about usage of PRP in post-acne and post-traumatic scars, burn scars, stretch marks, and telltale scars of burnt out diseases. So practically, I have the standardized method in my clinic. I use Y-cell BioKit or Renewcell kit, which is our glass tube. We use Remy's cold centrifuge, and we used 26 ml of blood through anticubital vein. Centrifugation is done at 3200 rpm for 4 minutes, and harvesting of 3 to 4 ml of PRP is done. But if in case the area is bigger, we take more blood, and proportionately we decide like how much blood is to be taken and how much PRP is to be harvested. So why PRP is to be used in scars? So here's this diagram from my book, which is recently published, and this is called The Elixir of PRP Therapy in Intervention Dermatology and Regenerative Trichology. And here you can see that in different cells and different tissues around the hair follicle and in the deeper layers of the skin, PRP has various growth factors. So whether this is fibroblasts, which are activated by FGF, PDGF, EGF, or TGF beta and 1NB, or it is angiogenesis, which is promoted through VEGF, PDGF, TGF beta, or there is nerve regeneration done by nerve growth factors, and similarly so many other factors which help in rejuvenating the epidermis and dermal layers. And these factors, all of them are present in the PRP in very high concentration. So I'm sharing few of my cases with you, and here you can see that this is a case of post-acne scars, and we've done a cocktail treatment of microneedling radiofrequency with pixel erbium YAG laser and PRP therapy, and we've done 3 sessions of this cocktail every time, all 3 combined together. And here you can see a good improvement in the skin texture, overall reflection, and reduction in the post-acne scars. This is another case where we have the post-traumatic scars. You can see 6 or 7 scars visible in the before photograph, and in the after photograph, again with the same combination, you can see barely two deep scars are visible now, and there is significant reduction in the other scars. This is a case of post-chickenpox scars, and we've done microneedling radiofrequency with PRP, and this is the result after 2 sessions of the combination treatment. This is a very interesting case. This was post varicella, and the scars looked like DLE. And here the patient was very deficient in her total protein intake. Her B12 and vitamin D levels were very low, and that could explain probably this kind of scars after chickenpox. And here we've done again a cocktail combination of MNRF, erbium YAG laser, and PRP therapy. And you can see the improvement after 3 sessions. Well, those depigmented scars can be punched out and sutured, but I lost this patient to follow up, and I hope that she's doing better than what she's doing presently. Now this is another interesting case. This is a case of stretch marks. She was a case of nephrotic syndrome as a child, and she came to me when she was 22 years of age. As a child, she was treated with heavy doses of steroids, and we took up 3 sessions of cocktail of MNRF, erbium YAG laser, and PRP to revise her stretch marks, and we can see there is significant reduction in the visibility. The stretch marks have become more shallow, and they're more blending with the epidermis, and overall she could take up the procedure very well. Her recovery time was very short, usually 3 to 4 days post procedure, because we could combine PRP with both the ablative procedure, and that gave her faster results. Now this is an interesting paper we published in Dermatologic Surgery. This is called LAPIST, or laser ablation of recipient area with PRP enriched epidermal suspension transplant in vitiligo surgery. Well, I'm not here to discuss the vitiligo surgery, but yeah, I've extrapolated the same technique. The LAPIST is modified here as RAPIST, where we've used radiofrequency ablation of this melanocytic nevus present on the nose of a young girl. And we've done PRP enriched epidermal suspension transplant, and we could avoid the flap surgery here, and I'm showing you the results after 3 months. This is another interesting case report of nerve endings regeneration with a cocktail of ablation, filling, and regeneration. Here, this patient had a post-accident crushed heel injury. He was given a pedicle graft from the thigh on this heel by a plastic surgeon. He came to me with repeated trophic ulcers, and he did not like the sight of the the graft, the pigmented skin, so he wanted it to be revised. And we started doing the erbium YAG laser, microneedling radiofrequency, and we did autologous fat transplant after 3 sessions to give some cushioning to his heel, and we were doing PRP therapy along with it. So after 3 sessions, the patient started telling me that, on the completely anesthetic area, which was like the heel was completely anesthetic, he started having some sensation, some pain sensations, and we could also see the skin texture was improving over that area. There was less frequency of trophic ulcers, and we could see the improvement. So this patient shifted to abroad, and then he came to us after 2.5 years, and I was completely taken aback looking at his skin texture. There was no trophic ulcer. He met with an injury, and this was the only anesthetic patch on this entire foot, and rest all area was completely normal, and they were all the pain sensations were there. The touch sensation was there. So this was quite astonishing again, that how the scar kept modifying over a period of 2.5 years with the cocktail of fat grafting, PRP therapy, and erbium YAG laser. Now I'm going to talk about the burn scars, and we have reported the revival of hair follicles and appendages, again with a cocktail of PRP, erbium YAG laser, and microneedling radiofrequency. This was a case series of different patients, and here we've taken the biopsies before and after the procedure. So you can see the before section shows completely barren area. There are no hair follicles and there's paucity of neurovascular bundle. Whereas the after photograph shows the tiny hair follicles and there are more vessels and nerves to be seen. Now, how the PRP helps in post-burn scars? Well, we've mentioned it in our book, The Elixir of PRP Therapy in Intervention Dermatology and Regenerative Trichology. So overall, the mechanism of action of PRP here is to improve the collagen type 1 via fibroblast stimulation. There's increase in elastic fibers. There is keratinocyte and melanocyte milieu by presence of fibroblast growth factors. There's new blood vessel formation. There is adipose tissue deposition, soft tissue augmentation, hair follicle regeneration and survival. There is initiation of nerve healing and regeneration, and there is restoration of balance between anti-inflammatory and pro-inflammatory stimuli. There's also bactericidal and antibacterial effect, and you can combine it with different therapies as we've demonstrated, which leads to improvement in pigmentation, vascularity, and the skin texture, and there is improved sensation and reduction in pain scores. And it also promotes the hair growth, and overall the patient satisfaction is high. There is reduced post-procedural erythema and edema, and there's faster recovery and reduced downtime with infection rate. Now, this is one of the photographs of my post-burn patient. You can see that there is marked improvement in the skin texture. The contractures have reduced, and these were better perceived in, when she was laughing or speaking. So, in burn scars, the photographs don't do as much justice as direct talking to them, and it's like very rewarding procedure. So this was a case of acute burn injury. I injected PRP, and this was the result after 5 days. She was burned with the cigarette butt in a pub, and she came to me in a very desperate condition, and because I thought of injecting PRP, and this is how it improved. So this is another case of burn with an electric wire, and he was a defense personnel. So there was, because of the keloid formation, there was difficulty in extension of the neck. And as he started doing the procedure with MNRF and PRP, his neck extension started improving, which is quite perceptible in the third photograph. So you can see that the asymmetry and the neck extension has markedly improved, and even the keloid has improved. Now, coming on to the other results. So again, this is a combination treatment, and there was reduction in the contractures also. This is the other side, and this is a case on the face burn. We did FUE hair transplant on the beard area. We did Alma hybrid laser, and this was 3 months later. And the same patient on the back of the scalp, and you can see that there's a burn scar. This is like on the day of surgery, and then we have 3 months later. So this is quite a fast improvement if we consider that this was a scarred skin, because even in a normal skin we have delayed 4 to 6 months duration that we see good results. But in his case, because combination was used, this is how he did. And again, this is the demonstration of the erbium YAG laser. be doing the PRP, and here there is injection on the face area as well. Right. So here we have a case report of scarring alopecia. This is published in Archives of Clinical and Medical Case Reports. And again, how it works, we have proposed golden anchorage and molecular locking of ectodermal and mesenchymal component. This is a hair model, and it shows how PRP works in different tissues and cells around the hair follicle, and it helps in improving the overall environment around the hair follicle. This is a case of frontal fibrosing alopecia, a very difficult condition to treat, and we have done the FUE hair transplant with PRP therapy, and this was the result after 8 months. This is a case of post-cleft lip surgery scar, and we've done FUE hair transplant with PRP injection. I also injected the PRP in the lip, and you can see that the defect has reduced almost by 50% over the lip area as well. And this is a case of post burn scar in the upper lip area, and we've done hair transplant with the PRP. This was 4 months later, and then I saw this patient after 7 years. So I would like to draw your attention towards the asymmetry of the lip, which is progressively increasing over time. So over years together, the healing cascade kept on working inside, and this is the result after years later. And this is the case of morphia, because the skin was very thin, papery thin, and I decided that I should do the punch biopsy FUE punch biopsy hair transplant rather than the FUE hair transplant. So I did some 2 millimeter 25 punches here, and I injected PRP. This was the result after 4 months, and then I lost her to follow up, and then she walked into my clinic after 10 years, and this is how she was doing. She did not want any revision surgery with FUE hair transplant. That was my plan earlier, but she was quite happy, and the morphia was completely gone here. This is an interesting case of a bending sinus formation following sebaceous cyst excision on the back. This was a deep, it was a ruptured sebaceous cyst, ruptured towards the pleural side, and it was a very difficult surgery. And then, as the scar was not healing, there was some serious discharge all the time. I was apprehending sinus formation there. So I did this platelet-rich fibrin matrix here, and I did a bandage for 10 days, and then this was the scar after 3 weeks. It took time, but then it healed finally, and this is what I want to share. Sorry. So yeah, this was the scar, and then we prepared platelet-rich fibrin matrix, and carefully, after all the sterile conditions, we implanted it over the non-healing wound, and where I was expecting that there's a sinus formation can be there, and secured it with the collagen dressing. And as I showed you that we had a completely healed scar in next 3 weeks. So again, this is the summary, and from my book, as I mentioned earlier. So overall, there's more collagen formation, fibroblast stimulation, increase in elastin fiber, new blood vessel formation, adipose tissue deposition, and soft tissue augmentation with the usage of PRP with combination of various modalities like ablative lasers and MNRF. And we can actually, it can lead to high patient satisfaction and decrease post-procedural arrhythmia and edema. There's faster recovery and reduced downtime, and there is definite improvement in the scar and the skin texture. So we need to be cautious with the past systemic steroids, and should not be given in past 2 weeks. There should not be any oral NSAIDs in past 1 week. There should be caution with hypercoagulative state due to OCP and smoking, and there should be caution with use of activated PRP with fillers and leukocyte with PRP and platelet-rich fibrin matrix, because here there's less platelet, more proteins, and there can be difference in oxygen-free radicals, lysosomal enzymes, growth factor concentration, their release and binding. So carry home message is that PRP is a futuristic elixir which, when used judiciously, can help us as a monotherapy and in cocktails to improve overall environment in the hostile area to take care of various ailments and permanent scars secondary to burnt out disease. This is also should be treated as a double-edged sword, as unlike with neutral medicine, we are here dealing with very high concentration of life cells, growth factors, and hormones, which have their own endocrine, paracrine, and enzymatic effects on different systems, which might need many more years of experience to decipher them rightly. So this is our PRP, our own dragon soldier with fire, and this is my book on PRP. And you can go into details of various scars and other treatments here. So this is my last slide. A sapling needs some air, some water, some sunshine, and some nutrients, and it has the courage to pierce the heart of a rock. Same is the story of revising a scar. Thank you so much.